Good afternoon, everybody. I'm Dr. Sachidanand, Vice Chancellor, Rajiv Gandhi University of Health Sciences. On behalf of Government of Karnataka, we have been organizing online training programs for all the healthcare workers, especially doctors, nurses, and allied health science specialists. And in a pursuit to train everybody in COVID-19 pandemic, this thing, so that we are all of us will be on same platform to understand this disease and also to update ourselves. This online training program has been organized, and today's program is the 45th program that we have organized in the last 1 month or so, 1.5 months. And today the training program is on role of surgeons in COVID-19. All of you are very eager to know the government of Karnataka had given directions not to conduct elective surgeries, and now there has been a relaxation. Elective surgeries can be taken up. How it has to be taken up, what has to be done, and other issues will be really bothering your mind. We have with us a panel of experts today. Dr. Pandu is a Senate member of Rajiv Gandhi University of Health Sciences and also Associate Professor at KIMS, Bangalore. He'll be the moderator today. And Dr. M. Ramesh, Chief of Laparoscopic and Bariatric Surgery, Fortis and AV Hospital. He'll be talking on outpatient testing and emergency care, and followed by Dr. Anand Alani, Professor and HOD, Department of Pediatric Surgery, BMCRI. He'll be talking on surgical perspectives of IP and ICU patients. Dr. H.V. Shivaram, Head of the Department of Surgery at Aster CMI, Bangalore. He'll be talking on surgery, prioritizing and precautions. And finally, Dr. B.C. Bhagwan, Syndicate Member and Senate Member, RGUHS, Vice Principal, Department of Surgery at KIMS. New norms of practice after lockdown. So I think there is a complete perspective of the issues that are relevant to today's situation. All the topics have been covered. But in spite of that, if all of you have doubts, you can always shoot your questions to the chat box that is available on your devices. Kindly send the question that will be taken up at the end of the discussion, at the end of the presentations, and all your doubts will be cleared. That is the program today, and I wish all of the whole objective of this program is to see that the authentic information is disseminated to each of us, because these are the times when a lot of rumors keep coming, and we tend to get lost within that information that is available to us, maybe on social media, maybe on WhatsApp. So all those, we should not be really depending on that. The slides have been prepared keeping in mind the Government of India directions, Government of Karnataka and WHO directions. And so you will get authentic information from the experts here. I wish the program all the best, and I request Dr. Pandu to take over and moderate the session. Thank you.
Certainly. Good afternoon, everyone. I welcome you all for this session. I am Dr. Panda. I am Associate Professor in the Department of Surgical Oncology, working in KIMS, Bangalore. Till today, we were all taking up only emergency cases. Now, the time I started that we are all started doing routine cases. So, as a surgeon, and we have all the doubts that whether to get COVID test, whether to which quality of PPE should be used, whether to do what is the routine cases, when to do, and all those things. We have an expert panelist here. They will present the things first, then we can have interactive sessions. First, I would welcome Dr. M. Ramesh. He is Chief of Laparoscopic and Bariatric Surgeon in Fortis Hospital. He will be speaking on outpatient testing and emergency case. Please, sir.
Good afternoon, everybody. My role here is to start off, get the ball rolling, and I will be talking to you about outpatient management and emergency surgery, emergency care, and also about testing of COVID and its importance. Now, the basic key concepts that we have in front of us today is that we have to limit how germs can enter the facility. We have to isolate symptomatic patients as soon as possible, and we have to protect healthcare workers. And with these three principles, key concepts behind us, we've got our guidelines formed, and we have to strictly and religiously follow that. I'll be using a little bit of pictures from Fortis Hospital. The picture that you see in the upper part is a patient sitting outside the hospital ready to go home. Even when they have left the hospital, till they leave our premises, we have to make sure that we look after their safety. There is social distancing. There is at least 2 meters distance between each seat that they are sitting in. And of course, we as doctors, surgeons, and our paramedical staff have to look after our own safety, which is of prime importance. So you can see this picture of PPEs being worn in the operation theater, which has become a normal protocol today in that hospital. So at the entrance of the hospital, the very fact that the people try to come in, there are a few things that we have to take care. One thing is we have to tell them if somebody has fever, they have to be strategically categorized and separated from the rest of the crowd. So there has to be a flu clinic, and the flu clinic should be slightly away. And then as they enter the hospital, there is a dispenser. Nobody's touching it. It's a foot-operated dispenser, and they use it to sterilize themselves. Today, there are a lot of gadgets. This is what we normally do. We have people checking and verifying everybody, but at the same time, to reduce risk for healthcare workers, there are a lot of technology coming into place. These are robots being used to check people and then actually tell us what is happening. This is a very short clip. You can just go through. It is a self-explanatory one using robots to filter
Hi.
patients.
Name please.
Sharat Kumar.
Phone number please.
9030-300-300.
Let me check your body temperature. Please take a step back and look into the camera. Your current body temperature is 100.8 degrees Fahrenheit. Do you have a fever, cough, throat pain or difficulty in breathing?
Yes, I'm feeling feverish.
The screening is complete. Now you will need to go to flu clinic for further assistance.
By the time he goes to the next robot, all the data goes over there.
Hi,
and
Sharon.
everything is analyzed.
I see that you have fever with high temperature. Let me connect you to the doctor.
How are you today?
I'm feeling feverish, doctor.
Do you have any throat pain or breathlessness?
No, doctor.
It looks to be normal fever and not COVID. Mitri will issue the entry pass for you.
Thank you.
Please collect your pass and proceed through gate number 2.
So this is how things are being used. Technology is coming to a great extent. It is helping us in preventing infections. All hospitals should identify a separate triage and holding area for patients with influenza-like illness, so that suspect COVID cases are triaged and managed away from the main outpatient department. This is very important, and everybody has to fill up a self-declaration form which has questions talking about their travel history, their contact history with infected patients, and the symptoms of COVID like fever, cough, throat, and breathlessness. And looking at that, we decide what has to be done with each patient. Looking at everything in a glance, this is what is prepared by the Indian Air Force some time ago in the beginning itself, and it is very simple and can be used by everybody. We have the green, amber, and the red with all the symptoms that can come with COVID infection. And also they have to look at what medical conditions they have, their age, everything is being taken into consideration. So looking at that, you can actually categorize everybody coming into the hospital into safe, those who are have to have caution, and those who may be in danger. So they look at these at home itself, and then they decide who has to go to the hospital. The green never have to go. The amber and the red have to come to the hospital. And in the hospital, this chart actually very simply tells us what to do with these patients. We have to take care of everything in the hospital and make sure that infection does not spread, especially something like COVID, where we do not know who is harboring the infection in themselves. So these are reception areas which are barricaded by a plastic film, and this plastic film is separating the hospital staff from the patients. And even here, the patients are at a very long distance from each other. So all these precautions have to be taken care of. And in the consultation room also, we have a plastic film that separates us. We stand here and then we examine the patient. Suddenly the patient coughs or sneezes, we are still protected out of it. And every time the patient comes out, you have to clean up and wipe those surfaces. So let us start looking at who should actually be practicing now since the lockdown is got over. I think people who are above 60 years, whether it is a nurse or a doctor, should not be practicing. And those who are immunocompromised should also stay away for some time before the infection actually settles down. And which are the patients to be avoided? Patients who you think are symptomatic individuals in the early phase of their disease, symptoms where those who are contacts of laboratory confirmed cases, those who are symptomatic healthcare personnel, and all hospitalized patients with SARI are these are the patients who actually have to be avoided in a normal hospital. Of course, COVID hospital is the place where they should be treated. And sometimes you can even send them directly for testing. So all those with patients with any of these positive findings should be sent off to a COVID center for testing. It can be a government diagnostic center or a private diagnostic center. And as far as possible today, we should try to look at managing our patients with the phone itself. Try to call them, find out whether you really have to see them, whether it is important. All the electives and the follow-ups, you can try to avoid and give whatever minor suggestions to them on the phone itself. Once they are in the hospital, the triage should be done by really adequately trained staff and make sure that nothing is missed out. And the physical barriers like this glass or plastic should be used, and social distance also has to be maintained. So I'll just give you an example of the triage that we are using at Fortis Hospital, which can be used. It is according to the guidelines, and you can always mimic the same thing or emulate the same thing. Somebody who's come with fever goes to the fever clinic, and then from there he goes to the ER. In the ER, there is a small triage center where a nurse is in charge, and she looks at the assessment of the patient, which should take about 5 minutes. And then this person decides whether this is a COVID suspect or a non-suspect. So if this is a COVID suspect with SARI ILI, then this patient is sent to a zone 1. And here we have a doctor and a nurse who are in charge here, and they take about an hour. And in this time, they do the basic tests, an ABG, an ECG, and a chest X-ray. And then they finally decide whether it is a non-COVID patient who goes to zone 2 and then goes to various departments, or if the patient is a COVID patient, patient goes to a COVID ward where a physician, pulmonologist, infectious disease specialist looks after, or patient can go for an outside reference or to the ICU, whatever is really required. And in the ICU, you have the pulmonologist, intensivist, and the ICU persons looking after. What is very important is the staff should be safe, and we of course, those who are directly in contact, we are following chemoprophylaxis with hydroxychloroquine. You should, as I said, restrict OPD, avoid walk-in patients, and avoid relatives as much as possible. So when an appointment is fixed, they're sent a message saying, please, with all these things, and they're asked to bring their own sanitization and sanitizer and a mask compulsorily. And when they come here also, they're told, please, only the patient has to come in, and patient's attender should stay away. And social distancing should be maintained wherever it is. Even all the diagnostic departments, this is the radiology department where patients are waiting here, and then the radiologist is in full PPE, and he's because radiologists, as we know, are very high risk to get into infection. And even small things like a pharmacy, we have to guide them properly by marking out areas where they should stay away, and then even in a lift, in an elevator, how they should stand. They should stand facing the elevator and away from each other. All these are very important. We have to guide them properly. And even in the consultation room, you have to be safe first, and then that is the prime concern. So we have a plastic shield. The patient sits here, so we are not actually worried about direct spread of droplets, and we do not touch the patient. We use a new prescription. We don't touch their files. We try to do as much of a non-touch techniques as possible. So we sometimes ask them to click photos of all the investigations and send it to us. And a doctor should wear a surgical mask. A scrub is very important. After seeing every patient, he has to disinfect his hands properly. And all patients with respiratory symptoms are made to wear a paper mask in the waiting area and instructed on cough and sneeze hygiene. So doctor clinics should be well ventilated, and the seating we have to, if you have a attached seats, the center seat you have to close it down and then make sure that they sit away from each other. It's very, very important. Except for physical examination, you make sure distancing is always there. You have to have a lot of alerts and a lot of displays all over talking about hygiene, about hand hygiene, respiratory hygiene, cough etiquettes, and every place in the hospital should have a sanitizer dispenser, if possible, by a foot operated, where nobody is touching things now. And whether you're talking about OPD, screening areas, ICUs, wards, everywhere. And alcohol rub should be used for 20 seconds. If you're washing your hands, then you should take at least 40 seconds. So there is a need to protect ourselves using this protective gears. And this, what we should wear depends on what actually you're doing in the hospital. We cannot spend exorbitantly for each and every person in the hospital, but at the same time, we have to customize and idealize the usage of every type of material. I'll just go through the whole list of what each one should wear. Looking at a receptionist, this person should have a full cover cloth dress, N95 mask, or a cloth mask over it, and then a face shield. In the fever outpatient clinic, people should have a full cloth dress, a mask, and then a face shield. Along with that, if they're checking the patient directly with BP and temperature, they should also be wearing gloves. The laboratory staff should have the mask, face shield, and the gloves because they are drawing blood for the patients. The housekeeping should have a plastic apron, the elbow level gloves, high level gloves, and leggings with cloth mask and face shield. We have the government actually spelling out everything very clearly. So I think we should follow these charts and look at what exactly PPE should be followed by which category of people and what risk they carry. And then how you wear it is also very important. The order in which you have to wear. First you wear the gown, then you wear the mask, then the goggles, and then the gloves. And then when you are removing it, it has to be the gloves first, and then the goggles, then the gown, then the mask, and then you wash your hands. So the donning and doffing is extremely important, and they have to be in different areas. So prophylactic drugs of hydroxychloroquine, many people are following it, but still there is no solid evidence about it. Right now there is a random control trial going on for 40,000 healthcare workers, and this is over 3 months. So they have begun recruiting, and initial results is eagerly awaited. This is certain etiquettes that you have to follow. Don't touch the doorknob when you are getting in. You have to use your elbow. Don't use the finger, but you should use your knuckle when you get into a lift. And the way that you should use a sanitizer, you properly use it and then rub it properly. We have the exact ways in which we have to use a hand rub. All that has to be followed. And then the sneezing and coughing etiquettes have to be followed very well, whether it is the staff or the patient. And wherever, whoever is there, social distancing has to be respected and followed religiously. And how you follow typing and pointing out gadgets, how you use the mask, remove the mask. You should never touch the front of the mask. And then how you remove the gloves. All these have to be taught repeatedly. We have to run these videos, make sure that all our staff have learned this properly and they follow it correctly. Sorry. And of course, even if you are wearing a face shield, you should be wearing a mask inside. What mask you wear, it all depends. But then a mask over which a face shield has to be used. As far as the changing scenarios are concerned, we should have a review committee, which should have the hospital administrator, infectious disease specialist, physician, surgeon, and the nursing in charge, along with the anesthetist and ICU specialist. And they have to keep making periodic guidelines based on what guidelines have come from outside, and they have to look at what are the practical things that they can do. And every hospital like NABH have to follow. And what do surgeons do when they're called to the ER? This is very important for surgeons. Try to get a detailed history from the emergency doctor, ER doctor, and then try to get as many records as possible away from the patient, and then make sure that you go into the ER for a very little time, minimal time, and then finish examination, come out, keep giving your orders and then let it be followed. And if the patient is planned for surgery, you can order for a COVID test, and surgery is in designated OT and post-op care in designated ward has to be done. And follow-up with COVID test has to be done, because supposing the report has not come before surgery, you should take proper precautions and then follow what is happening. As far as the tests are concerned, we basically have the PCR, RNA test and the serological test. The real-time reverse transcription polymerase chain reaction is what is followed all over the world now. We take the specimen through a nasopharyngeal swab, which takes some amount of mucus and saliva. It goes into the nose and then up to the throat. And then this, you are looking for specific genetic material from the pathogen in this. Serological tells us about possible infection and exposure in the past, but not if current infections are there. And it only helps us more in the rate of infection in a community. So if you look at what is actually happening, a patient may be there in a yellow zone where he may be at risk of getting COVID infection. But once he's got infection, it is the RT-PCR test which is positive. And later on, the antibodies start coming. The IgM comes a little early, and then the IgG is there for a long time. IgM goes away later on. So these are the tests to be done at these particular periods. So to summarize, there is no particular test that can be positive throughout. In the active phase, this is there, and even this, there is 30% false negative results with RT-PCR. And to add to these problems, we also have the major challenge of shortage of kits. And so though we want to test everybody who's getting into the hospital, it is not really possible. And so today I would say you have to follow proper precautions, a universal precaution. Consider everybody walking into as a COVID positive patient, and then play safe. Safe for yourself, safe for your healthcare workers, your colleagues, and safety for your patients has to be taken care. Thank you for a patient hearing.
Thank you, sir. So thank you, sir. Thank you for your wonderful presentation. So one point I would like to stress here is every hospital should have a single point of entry. So many hospitals will be having 2-3 entry points. So we should restrict for the single point of entry. And in many hospitals, security fellow will be there to check the temperature. So you won't be able to take the history properly. So screening point is very important. We should have a sister and a doctor who can take the history properly. So nowadays, as of now, as my colleagues were telling, people are not giving the history of fever. So, and also they are not disclosing the address also properly, because if they have come from the red zone, they are trying to hide the history. So that's why we should be very careful at the entry point, and the sanitization of all the attendants should be done. So security fellows, we should take the help of the security fellows and restrict the number of attendants entering in the hospital. And also, as sir told, the RT-PCR test, what is available now is false negative rate is 30%. So we should be very careful while working all those things. So next speaker is Dr. Anand Alladi sir. Is a professor and head of the department in pediatric surgery, BMC, Bangalore Medical College. He will be speaking on surgical perspectives of IP and ICU patients. Please welcome, sir.
Good afternoon. So part of my topic is only running through medical issues, because most of you as surgeons will not be actually directly concerned with treatment of COVID patients. In the present scenario, we have four situations or 4 localities where patients are housed. And with the new guidelines coming out for home isolation also recently from the Ministry of Health. So that is one option. So these are patients which you would never be directly coming into contact. And hopefully they wouldn't be taking appointments and actually coming to you hiding their history. COVID care centers, which are again mostly asymptomatic patients who have been kept for isolation, or with those with COVID, some sort of mild comorbidities. The ones which we are generally looking at would be patients who are in the dedicated COVID hospital. Now, these may be standalone hospitals where you might be sort of called to give a surgical consultation for some suspected surgical problem in a medical patient, or it may be part of a hospital, which is in most of the situations, unlike in a few situations where it's only a COVID hospital, but many places there are parts of hospital which have been converted into COVID area, and the routine non-COVID work continues to take place. So these are 2 areas where you might get inpatients, where you will be called in for surgical consultations, or you might have an emergency surgical patients coming in where you are still not sure whether it's a negative or a positive patient, and treating them as a suspect patient. Just to briefly go through what we generally come across in COVID patients, most of them are categorized as 3 groups. The green are the one with the asymptomatic or very mild symptom, which could actually be home quarantine or in isolation centers. The orange and the red ones are the ones who generally end up being inpatients, and red ones being obviously the ones who are in ICUs. So the medical categorizations are all self-explanatory. So mild symptoms or with saturations dropping lower to some extent, with no other major requirement of inotropes or supportive treatment, are the orange ones. We might progress on ending up in ICU, going on to requiring full-fledged support, resuscitation, or ventilatory support. So these 2 groups may have surgical patients. You may have an emergency surgical patient fitting into any of these areas. Patient coming with acute appendicitis, patient coming with perforated gallbladder, intestinal perforation, but otherwise having mild or asymptomatic with respect to COVID. I'm not talking about the symptom with respect to the surgical pathology. Or patients who have been admitted with moderate symptoms, or confirmed patients ending up with having some sort of a surgical emergency which needs intervention. Most of the management for the general patients are all supportive, no specific treatment depending on the category. It is just supportive measures, paracetamol for fever, oxygen if there is any requirement of the same. High-risk individuals with comorbidities looked at with respect to the comorbidities, and simultaneous management for that going on, and ICU care and other emergency supportive measures when required. Depending on the specific category, you may have to give them specific additional treatment. The general evaluation is common for all any other patient, and ECG is added on. Most of the adult patient, of course, will be getting ECG for other reasons also, if you are going into surgery from the anesthesia pre-op evaluation point of view. But basically, the ECG is part of the routine protocol, because all of them would be getting HCQ, and HCQ is contraindicated in specific cardiac issues, especially when there is prolonged QT interval and they are known to go in for blocks or bradycardia. So that is one of the routine evaluation before they are started on the treatment. And in those who are high-risk patients, continue to be monitored with respect to their progress and prognosis. So there are certain markers which will be done at periodic intervals to see whether it is improving, static, or worsening, and which helps us in categorization into those with poorer prognosis. Specific treatment with respect to COVID, all of them get an antiviral, azithromycin and HCQs where there is no contraindication, supportive treatment, and in addition to that, if they are symptomatic with coughs, mucolytics, and those who have severe group, those who fell into the severe category, the red zone, will also get low molecular weight heparin to prevent pulmonary thromboembolism, because this has been one of the reasons which contribute significantly to mortality and severe morbidity. Those who have been admitted, managed well, and become asymptomatic are discharged after 2 negative swabs show negative reports on 2 consecutive days after 14 days of quarantine. Suppose one of them turn out to be positive, the test is repeated again after 3 days. Until we have this stage, they are continued to in hospital and discharged subsequently. Pediatric patients do form a special group in certain situations, especially when a child is positive and parents are negative. It may look surprising that you expect both the parents to be negative and the child is positive, but we have had patients in this category, maybe because there are grandparents who are positive from which they got it, or sometimes they might have got it from other children with playing. So these may require special care, because you cannot mix them in a regular, mix the negative parent with regular patients. So you'll have to have a separate care facility for those groups. With respect to management of IP patients, a lot of logistics come into picture, the type of manpower. If you are a complete COVID hospital, of course, as surgeons, you wouldn't be involved in all these issues of management, but there are hospitals where there'll be certain areas where there are COVID patients kept, and certain areas which are used for isolation, certain which regular normal patients are kept. So distribution of manpower with respect to the 3 areas, how the duties are done, how the rotations, whether you need to put them, give them adequate recovery period, whether you need to actually send them for quarantine, or whether you can just ask them to go back to a different area for duties after that, will be all something which local administrators will come up with policies. There's no uniform policies, even within the country. For example, when we are using patient manpower in COVID positive areas, the doctors and nurses, certain areas like Bombay, Maharashtra, where the load is so much, they are doing rotation of 1 week in a COVID area with all PPEs and being isolated in a separate hospital during that time. And the next week, after they finish the week, they go back to working in non-COVID area without actually rest. So manpower availability, the number of patient load, and all those things will dictate how you can safely rotate these people. So in BFC, the Victoria Hospital, which is sort of a unique situation that we've been converted into a complete COVID hospital, we do not see any non-COVID patients. Only patients who have been confirmed COVID as referred here. So as surgeons, there is not much of work here except those one odd patient who might end up having a surgical pathology, or a patient with a surgical pathology who turns out to be positive, either because they are tested due to some indication, or some have also actually started doing routine testing in certain patients and it turned out to be positive and he has an emergency surgical requirement, they end up coming here. So what happens, I think Dr. Ramesh has already spoken to about how to take care, prevent as much as contact, avoid direct exposure and minimum exposure of healthcare workers, trying to see. So what we have actually done is the ward dedicated area is been it's quite far off area, and there's a control room from which people monitor. There are apps. There are also certain robotic things where actual healthcare workers don't directly go in and touch the patient. Now, recently, there are a few people who have come up with monitors which have got multi-para monitors equivalent, which can be put on the patients and remotely monitored at a very far off place. Patients can be, the duty doctors and nurses or in the wards can interact with the senior people or senior faculty in case there are any help they need or any opinions they need. Patients can be counseled, even psychiatric counseling going on online with the patients from a remote center. So a lot of things can be done without actually having to directly come into contact with patient. And the same thing can be applied to even hospitals where you have a mixture of patients, both COVID, non-COVID, by remote monitoring and remote treatment. So the minimum amount of healthcare workers are exposed to these people, and that way you can sort of keep your pool running and active and have the energy to go for a longer time. So those are all the small amount of information with respect to the medical management and what we actually come in day to day with COVID positive patient. But as surgeons, I'm sure most of us are interested in knowing what are the present scenarios with respect to surgery, when can we start going back to our work, when can we safely say we can take care of patients, and a lot of questions come into mind. Now, as a surgeon, you might be, as I told, called for giving surgical opinion in a patient who's admitted either as a normal patient or as a suspect patient or in a confirmed patient, or you might be called in to do an emergency surgery in patients who are admitted belonging to any of the category. So present day, basically there are two groups: routine surgical situations and emergency surgical situation. The details of which segregation and all, Doctor, I will not go into it right now. Basically, at the present situation, though they have started to say that you can start doing routine surgery, but I think it would be more prudent to wait and defer those patients whom you can comfortably defer for significant period of time till at least we are sort of safe guidelines to decide how we can go about treating this group of patients. And the reason is that even if you are geared up and you want to do some major surgeries, in positive patients, there has been, you may be able to take proper precautions using proper PPE. You may have the complete state-of-art, facility, infrastructures, everything. But there has been a definite increased morbidity in patients who are positive, even for routine surgeries, not the comorbidities and for emergency surgeries. So definitely there is something to think about and probably defer these patients and wait for some more time before we start thinking of routine surgeries. Yes, if you look at it, many groups of surgeons, there are people who are salaried in government institution and have the safety of their finances being looked after. There are people who are into corporate sort of practice where they have to depend on generating patients, operating on patients and keep the thing going. There are people in second and third level towns and township cities, smaller cities, where you cannot keep going on without doing anything, especially as surgeon, because you have to definitely earn your living. Most of us, I think, financially would be able to manage and push for some time, but we will have to look at titrating all these things, keeping few things in mind. One, what is considered safe? Whether you have a negative report is enough to say that we can do surgery in this patient without any risk. That is again coming into question, which already Dr. Ramesh has talked about, false negatives being there. False negatives due to many reasons. And now recently we had a false positive also, so it turned out to be negative. So I think there are specific issues with the relying only on the RT-PCR and then saying, no, I will do routine RT-PCR in all patients. And if they're positive, if they're negative, I am safe. So I can start routine surgery. The other problem with this is many hospitals have started saying that we will do routine RT-PCR, but the government guidelines, if you see, though more and more private labs have been now recruited to start doing the test, there's still a limit on the number of tests available, and the guidelines which keep changing, which is dynamic. The fresh guidelines does not still say you can do routine PCR for all pre-op patients. There are certain individual states who have permitted doing random screening. So how do many of the people get away doing routine PCRs and say we will do routine PCRs as pre-op investigation? There are, if you look at the mandatory forms, there is a category which says others. So maybe they are using that and as a for default selection criteria and sending off samples and then saying they're negative. But whatever you do, whether you're circumventing the guidelines and managing to do it as a routine pre-op investigation, or you still do it and you may be in the group of patients who are having false negative, it is safer to consider everybody as positive for the time being before you go in and start doing. And then comes the issue of PPEs. Now, if you decide that I'm going to consider universal precaution and use PPE for all patients, there are a lot of other logistics. One, what is a proper PPE ideal for those surgeries? If you do so, can you do complete prolonged surgeries using those PPEs? Is it comfortable? There are a lot of PPEs available. Pictures are seen, surgeons wearing PPE, but personally, if any of you have tried using PPE, a proper PPE, the basic principle of a PPE is the safety of the PPE is inversely proportional to the comfort of wearing that PPE. The more comfortable you are at the PPE, the less likely to be completely safe, except if it is one of those exceptionally high quality PPEs which are both comfortable and safe, which is not something which you would get routinely everywhere easily. So then if you are using PPE with clumsiness, discomfort, and trying to do very fine surgeries, which require a lot of intense concentration and handling, are we likely to be compromising on the quality of surgeries? So these are all errors of surgeries. Lots of things come into play. So probably this is something which you should also consider in mind before we start doing routine universal precautions for all patients. Coming to those group where we say we will use, those who are highly suspect or positive patient and still go ahead with surgery, especially those who are having emergency surgery requirement. One of the recommendation was to have, of course, in addition to all these things, there are a lot of other things which come into picture. The way the anesthesia to be given, how early the anesthetist start, how much extra time take between cases when you are doing positive cases, the way to don the PPE, how to use the PPE with sterility, whether you use PPE which are already sterilized available or you have PPE which are unsterile. If so, how do you scrub? How do you scrub and then wear the PPE over it, or you just wear the PPE and take care of only the hands part of it? So there are a lot of things which come into thoughts when we actually come to the ground level and start using the PPE in the OTs. Negative pressure OT is something which is a concept which is there, where you have an additional room where the air is sucked out. So the air comes in and the air goes out. Basically, it's like an exhaust phenomena into a certain area. And from that area, that air which is come out from the OT is either treated with various ways of treating, or it is let out at a very high level of more than around 3 meters above the roof of the thing, so that it goes off into atmospheric air. So there are certain additional modifications of your OT you might have to do. Now, if you decide to do that and you want to actually start operating on suspect or positive patient using this as a additional protective measure, there are certain things you'll have to consider. What is the cost of using this? That depends on your OT, the surface area which is required to be converted into negative pressure OT. There are in the markets ranging anywhere from 5 to 25 lakhs you may have to invest. If it's something which is going to be doing on a large scale, multiple surgeries, it might be worthwhile investing. And the more expensive ones are something which after, obviously we will be thinking of this as a short-term investment. If you're going to be looking at having a negative pressure OT after 6 months to a year, if COVID is completely out of the picture, what is happening to your investment? So there are some companies where you can convert this negative pressure equipment into giving it into a positive pressure OT later on. So it's still something which you can consider if you want to use that as a tool for having a safe OT. So these are all things which come into picture. So keeping all these things back in mind, what should we be trying to do about it? Should we do routine testing? This we have already answered to some extent, looking at the aspects of the routine testings availability and drawbacks of test results. Whether when we do emergency surgeries, how do we go about it? Now, these are all something which have to titrate. One option is, for example, if you are in a either it's multiple corporates in a big city or even in a small city or towns where you have multiple nursing homes or small hospital, you could start a group institutional practice where few of you get together and decide that we identify the 4 hospitals in different areas and put into this hospital specific type of patient. So you might be doing confirmed simple daycare or routine surgeries in one hospital. You might be doing hardcore suspect or positive major cases in another hospital. So all that infrastructure and investment with respect to PPE and OT preparation can be put into that hospital. And the group of people owning that can all come together and share the revenue, both the investment and the earnings. So these are all, the COVID is going to go a long way in coming out with a lot of new things in our general day-to-day practice. What is normal, the new normal may be completely different than what we used to have before. So this may be again something which you could think of. So at this point of time, I think I will stop here, and maybe once the other speakers are done, we can take on questions with respect to this. Thank you.
Thank you, sir, for the excellent presentation. Sir has come from Victoria Hospital, where they treat only COVID positive patients. So as of now in Bangalore, we have two government hospitals, Victoria and Rajiv Gandhi Hospital, and in private, I think Manipal and St. John's, they are treating boring. Boring, they take suspected cases. If they come positive, they'll get referred to Victoria. So Manipal and St. John's are the two COVID positive patients. As the cases increase in future, every hospital might be geared up for treating COVID positive patients. So this presentation was very important in how to treat the patients, inpatient, and all those things. So one important slide I would like to stress is that if the patient is COVID negative, whether to use PPE kit or not. So since the PCR sensitivity is only 70%, we have 30% false negative cases. So PPE kit is must if the COVID test is negative also. Then third point is the OT, operation theatre. So as sir told, we should have negative pressure. We don't know how many OTs are having negative pressure operating theatre. So sir, Dr. Shuram sir is the next speaker. He will speak on surgery, prioritizing and precautions. He is the head of the Department of Surgery and Allied Branches in Astra CMI Hospital. Welcome, sir.
Thank you, Dr. Pandit. At the outset, I must congratulate the Rajiv Gandhi University for being proactive in training the surgeons and also educating all the surgical community about this invisible enemy who has attacked us and how we can save ourselves and also our patients from this pandemic. Thank you, Dr. Pandu and Dr. Bhagwan, for inviting us to give our thoughts on this. So my topic is on surgery, prioritizing and precautions. Okay. Really, surgeons are at crossroads now because many of us are confused which way we have to go, whether to operate, not to operate, if we have to operate, what precautions we have to take, which patients to operate, all these things. I think for the last 1.5 months, we have all done a lot of webinars. You also have listened to a lot of webinars, and the problem is there are a lot of changing scenarios and changing guidelines, and it's very important for all of us to visit the authenticated websites, especially the WHO, CDC, ICMR, RGUHS, and the Ministry of Health of Government of India. These things will give us authentic information, and I think if you keep on visiting these places, they will have more information and we will be updated. Basically, as Dr. Ramesh said, there are 4 things we surgeons have to take care. One is protect our face. When I say face, it is the mouth, nose, and eyes. They should be covered and appropriately whenever we are dealing with these patients. So if we can, because these are all respiratory tract virus COVID, which can enter our body through these 3 main entries. So we have to block those entries for this invisible enemy. So do not, while you are operating, don't allow surgical smoke, or we call it as plumes, smoke along with these particles of the blood and body fluids. They should not enter into our lungs because they contain the viral particles and they can contaminate. So that is another thing which is very, very important to take care while we are operating. Third thing is the hand hygiene. This is 24 hours. All the time we have to take care so that hand hygiene is very well maintained. And the simple thing, the war we have against this is the soap, and next is the 70% alcohol. One of them we can use. The soap is the simplest thing we can use and we can kill these viruses. The fourth important thing is this stealth transmission which is occurring. Lot of asymptomatic patients may be harboring this. So treat every patient as possible COVID positive patient. So this is one thing we have to think about it all the time, that any patient can be COVID positive. So then we can go ahead it. So All the while from our MBBS days, we were told our priority is patient. That take care of your patient, save the patient life. That's what we took the Hippocratic oath also. Now we have to add that we have to save ourselves, protect ourselves, and also the co-healthcare workers. This is another dimension which has added to our day-to-day practice. If you see the healthcare workers from the beginning, whether it is from China up to now, all over, plenty of healthcare workers have been affected. A lot of them people have died, and we have a lot of instances where without understanding surgeons have operated, they got infected and they have died. So it's very, very important that we understand the problem of this, especially the anesthetist and all kinds of surgeons and the frontline workers who come into contact with these COVID-19 patients. We have to protect ourselves first, save ourselves first, and then the patient. So coming to the surgery category, we have a lot of classifications come after this pandemic, and most important, easy to understand is put them into basically two categories, that is the emergency and urgent surgeries. And the third one may be the elective. Emergency surgeries ones which are, whether it's the positive, negative, whatever it is, we have to save the patient's life. We have to do it within hours. So less than 1 hour, maybe few hours. The urgent surgery is one which can wait for few hours. Maybe we have to do within 24 hours. Then there is urgent elective surgery, which we may have to do within 2 weeks also. Then there is elective essential and elective discretionary. So these are the things we are not in a very much of hurry, but category 1, 2, and 3, we may be forced to operate, and we may have to operate considering the life of the patient. So let us look into these things little carefully. So this is one of the classification which appears to be easier. There are so many things different organizations have brought out. Coming to the emergency surgery, which we have to do within hours, these are life-threatening emergencies like acute hemorrhagic shock, severe trauma, vascular injury, aortic dissection, emergency sections. So these are all we have to operate as early as possible because they are life-saving. Then there is urgent surgery, which we have to do within 24 hours, maybe like acute appendicitis, acute cholecystitis, or gangrenous cholecystitis, septic arthritis, open fractures, bleeding pelvic fractures. These are the things which we cannot wait too long, which may be detrimental to the patient's life. So we have to operate. Then there are urgent elective, as I said, these are within 2 weeks, like cardiothoracic, the cerebral aneurysms, vascular access, scheduled cesarean sections, closed fractures. This we may have to do within 2 weeks. And then elective essential is most of the cancer surgeries come into this categories. And then more than 3 months you can wait, like the bariatric surgery, cosmetic surgery, joint replacements. These are all we can consider as elective discretionary. There is no hurry to operate them. We can go wait for some more time and then operate. I think this classification, if you follow, this appears quite appropriate, which is published in one of the journals. The American, all following this, that is called the MENT score classification, where they classify according to the medically necessary, time-sensitive procedures. The scoring system, it's little cumbersome. You can go through this article in the Journal of American College of Surgeons. So that is another way of dealing with this. Basically, what we surgeons have to understand is with the COVID patient, they are not like normally operating patients. There is what is known as aerosol generating procedures. Most of the things, whether we intubate the patient, extubate the patient, wherever we come in contact with these contact fluids can enter into the lungs of the healthcare workers. They're all aerosol generating. Whenever we use these, especially the body fluid, blood and cautery or harmonic scalpel and energy sources, the smoke may contain variety of toxic and virulent materials. This is what we have learned from previous experience of the human papilloma virus and also the hepatitis virus, but we have not yet proved this in COVID-19 patients, but we have understood that patients, surgeons and healthcare workers who have been exposed to these things without protection, they have all got this infection and many people have been died. So it's always take this as the positive and then take all precautions. I'm sure in the course of time this also will be proved for the COVID-19 patients. So they are all potentially capable of infecting the healthcare workers in the OT, especially when they inhale these particles. So that's why the aerosol generating procedures are the most important thing, especially the laparoscopic surgery, where we use the pneumoperitoneum and these particles can escape when we release the CO2 into the OT air or something. So that's why this is where we have to take a lot of precautions. So that's why Dr. Anand said about the appropriate PPE, and we have to use our discretion whether to do laparoscopic surgery or open surgery. There's a lot of debate in this, even in the SAGES, everything. Most important is to decide whether the laparoscopy is beneficial to patient, like an obese patient who has a appendicitis or a acute gallbladder. It may be more safer for surgeon to operate open, but it's much more safer and also easy for the patient to recover. Minimum number of personnel in the operating room. Avoid movement of the the healthcare workers in and out of the OT. And we have to use smoke evacuators when using electrocautery or the energy sources. There are two types of filters. That is the high efficiency particulate air filters. HEPA filters is available in most of the OTs, and this can filter most of our whatever is invisible particles, and the other one is still better, that's the ULPA filters. So we should have the multifaceted approach, proper room air filtration and ventilation, appropriate PPE, smoke evacuation devices with suction and filtration system, and minimal use of cautery and energy devices. So if you see, every OT now is having a protocol along with anesthetist and the OT managers. Dr. Bhagavan was emphasizing there should be a very good coordination between the employers and also the employees. So because all these things cannot be done just by surgeon himself, there should be a good coordination between the employers and also the employees. And as Dr. Ramesh said, there should be a good hospital COVID committee or the infection control committee, which can make all these guidelines. SAGES has given very good guidelines about the filtration during laparoscopic surgery. You can all go through this. So what happens when you are doing laparoscopy, when the CO2 is released, how it should not be allowed to enter into the OT room, and it should be always filtered. And there are so many things which we can do, small things, especially while doing laparoscopic surgery. So these are very important so that we don't harm ourselves and also the other healthcare workers. There are many companies which have come out with this air seal system and also the surgical smoke evacuation and filtration systems. They have very good filters which we can all may have to invest and use these things so that whatever is coming out of the pneumoperitoneum abdomen to the outside becomes safe to inhale, both for anesthetists, surgeons, and also the healthcare workers who are all there. This is another guidelines recommendation from the inter-association of all these IAGES, AMASI, everything. Negative pressure, OT, Dr. Alladi has already explained. It may not be possible all the time, but it's desirable. Many of the hospitals have a negative pressure room in the isolation ward, so that can be utilized for some time. Minimum number of persons very important in the OT, and also when there is extubation, when there is intubation, better only minimum number of people are there, nursing staff, surgeons should not be inside the OT. Limit the size of surgical team. We are all used to a lot of postgraduates and interns, everybody around. When we are operating, all those we may have to cut down. Avoid the operating room personnel stepping out of OT. This already I told. And it's better to do the surgery as quickly as possible. And the training may not be possible during this time of situations of endemic. Better not to do training induced this time, wait for those things. Avoid multiple and complex surgeries, procedures. And reusable accessories are cleaned and disinfected. This is very, very important that we should not infect others. And 1% sodium hypochlorite solution is one which is now recommended for OT tables and trolleys, cleaning, all those things. And the in between the procedures also we are giving enough of time. Coming to the operation theater specifications, we have already good parameters which are laid down by the NIPH. Air changes per hour. This is very important. If you don't have a negative pressure OT, you just check in all your OTs whether there are enough of air changes per hour, more than 20. Most of the OTs of modern OTs have more than 20 or 30 air exchanges per hour, and the velocity and the pressure inside the OT, air handling and filtration. Every OT and hospital has an air handling unit, and they all have HEPA filters. This we have to check whether they are working or not, and the temperature, humidity. So some of the specifications, we may have to go through this again through the hospital maintenance staff and see whether they are all working or not. Laparoscopy versus open surgery, I just touched upon that laparoscopy is a aerosol generating procedures. So carefully select and see that which is beneficial to the patient and safe to the surgeon and to the healthcare workers, benefit workers as risk. So you have to take care of all these infection due to port site leaks, plumes, spillage of body fluids, closed room air circulation in OT, and then take the decision appropriately. It should be best for the patient and good for the surgeon and the other OT staff. Again, going to the post-operative care or ward rounds, have minimal staff. There is no need to do grand rounds and all. You can do the minimal persons and then inform the other people. Careful monitoring of the patient is very, very important. Even though RT-PCR are negative, we have seen that they may be false negatives. So post-surgery, some of them may demonstrate the COVID. So we have to check carefully the fever and symptoms for any COVID like throat pain, better to ask. And also we are not used to examine the chest, better to examine the chest and cardiovascular system for any missed heartbeats or anything. If there is a doubt, better to do the chest X-ray or a CT of the chest. So that's much more sensitive. What has been found is if you see that there is lymphopenia less than 1500 or higher NLR, then the prognosis may be poor. So there is a lot of viral shedding can occur in the body fluids and the feces. So it's always be very carefully dispose of these things and not allow any contamination of the patient and discharge the patient as early as possible. Another problem which we face is what to do if the post-surgery COVID test comes positive or unsuspected or asymptomatic case. So this is again a very difficult situation. This is where a lot of nursing homes and smaller hospitals are being closed when they come positive. So in these situations, hospital COVID committee or the infection control committee is very, very important for them to play a vital role. They should do a detailed interview with all those involved, inpatient care from ER to ward and OT to ICU, so that they interview all of them see whether they have used appropriate PPE, how much the duration they have used, whether they have disposed it up properly or not. This should not be a fault finding committee. It should be just find out the facts and whether there is any lacunae. So if you do this properly, then we will have two situations. In one situation, all preventive measures have taken, but there is a lacunae. In that case, the healthcare workers may have to be home quarantined for 2 weeks. They may have to start it on HCQ prophylaxis and daily twice temperature checkup and COVID test for after 4 to 6 days to know whether any of them have become positive. Then the area where all this patient has moved has to be sanitized and then opened maybe after 1 or 2 days later for the regular use. So then the other situation is all preventive measures are taken, but there is no lacunae and everything has gone off well, like in the case of any COVID hospital. Then the healthcare worker can go to work, but twice daily temperature has to be checked and they should be monitored for 4 weeks carefully. So then if they develop any symptoms, they may have to undergo tests. So all these are possible if there is a good hospital COVID committee meeting or anything. Otherwise, you may be under pressure from the external agencies to close the hospital or so. So, ladies and gentlemen, please understand that we never had a situation like this. Now operating is a occupational hazard for surgeons. So we have to practice with lot of care, taking all precautions and strengthening the awareness, not only for us, but also the surrounding healthcare workers, and then take all protocols established, keep updated very well with all the available knowledge, and then do the appropriate surgery. Other situations surgeons may face is that some of the recovered patients who have recovered from the COVID-19, they may come from elective surgery asking for surgery. So this is again, we have to be very careful. So our history now should include whether they were admitted for any COVID-19 related problems, whether they had COVID positive. There is no hurry to operate in these patients. A long-term effect of COVID disease is not known. We know that a lot of these patients may have severe disease. There may be lung restriction. They may have problems and long-term residual effect in the lungs may be there. So wait and watch policy for some time may be better. If we have to operate for any urgent situation, it's always better to have a multidisciplinary team meeting and then take a decision so that no fault comes on any of the people. Resumption of elective surgery. There are good guidelines from the American College of Surgeons. They have specifically taken into 4 important areas. This has to be carefully considered, not now, but after the lockdown period is over. And as we resume the elective surgeries, local hospital COVID committee again is the right authority to decide whether to go ahead or not. So this cannot be generalized. I think each hospital, each area, and also the situation upon depending on that, we have to carefully consider. We have to know our community and testing availability, whether which are the red zones, hot zones, containment zones, whether the second wave is coming, whether we have to withhold elective surgeries. We have to be very, very vigilant. And the preparedness is very important. We should have enough of healthcare workers, preparedness, healthcare facility, OT preparedness, interdepartmental cooperation. So this is preparedness is very important. Next is the patient issues. We should have good communication, consent issues to be sorted out. We should not get into any medical legal problems, and the prioritization we already discussed. And when we give the appropriate surgery and care, there are about 5 phases where we have to be very careful. Pre-op period, immediate pre-operative period is better as far as possible to keep the patient very minimum in the hospital, better so allow EROS protocol, intra-operative period, post-operative period, and the post-discharge period. all these guidelines and set protocols are there, then it becomes easy to resume the elective surgery depending on the local situation and how the problem is evolving. So thank you everybody. So knowledge is power, community is strength, and positive attitude is everything. We are a big community of surgeons. We have a lot of associations and the Rajiv Gandhi University and other strong institutions to back on. Whenever somebody has problems, you can definitely approach any one of us, and also the institutions, associations, guidelines, and the latest knowledge. And I'm sure we definitely come over this pandemic and come out strong and success and definitely victorious. And we will save not only our patients and protect all our healthcare workers and the surgeons. Thank you. Thank you very much.
Thank you very much for this wonderful presentation, sir. Sir, stressed one thing, save the patient life is one thing. So now we have to add to that, protect ourselves and save ourselves and our family. So all the hospitals have started already doing routine surgeries. So in each hospital, COVID control committee should be there. That COVID control committee should be mandatory, and all the cases who are going for the routine surgery should go through those committees. Is it, sir?
Correct.
Correct. So because only surgeons are not exposed to the risk, anesthetist, anesthesia assistant, OT technicians, sisters, sweepers, many in an OT, minimum 10 people will be involved. So the protecting all other paramedical workers and our colleagues is also our responsibility. So when it comes to laparoscopic surgery or open surgery, that is a dilemma. So as sir told, whichever is beneficial to the patient and also in which you are expertise. If you are more comfortable with open, go ahead with the open surgery. Avoid laparoscopic surgery. So aerosol generating surgeries like orthopedic surgeries, ENT surgeries, and laparoscopic surgery, and also long surgeries like oncosurgeon surgeries are at risk of exposure. So we should be very careful in selecting those cases. So next speaker is Dr. Bhagwan sir. Dr. Bhagwan is Vice Principal, KIMS, Kempegowda Institute of Medical Sciences, is a Senate and Syndicate member of Rajiv Gandhi Health University. Sir, please take over.
Good afternoon, everybody. Thank you for the opportunity. My topic is restarting planned surgery in the context of the COVID-19 pandemic, the new norms. Most of the speakers here have already covered all the subjects, actually, topic. My job is only to summarize what has been covered now. See, the elective surgeries, as you all know, were suspended during COVID-19, and all of us would like to restart. As our Vice Chancellor pointed out, that the go-ahead has been given for to plan the surgery, especially elective surgeries. We all should understand that this COVID is likely to be with us, and it's going to be with us for many months, probably for a number of years. And all the surgeons, we have the fear of getting infected at some point of time in the future. We had the fear when we were sitting at home, and some of us also had the fear that we may lose our jobs. Looking at the economy of the country, some of us had the fear that our salaries would be cut. But thanks to all the government agencies and the leaders in the management, that we have been assured that a lot of prizes and blessings are there on the surgeons. As you watch the media, they have supported the doctors community, luckily, and we are thankful to them. And the IT people did work from home. We all worked at home. We were working at home. Some of us learned so many new things going through webinar, and then saw movies and read poetry, things like that. And I did also learn about mopping and sweeping and all that at home. Many of you would have done that. And when I wanted to come out of that, my wife said the government has said not to take you out of the job. So I need to continue my mopping and sweeping for some more time probably. And as you all know, there's going to be increased demand on critical care, and this is going to be there for quite some time. And we all have to stay updated through the guidelines, as Dr. Shivaram just now mentioned, uh, guidelines of ICMR, WHO, Government of India and state governments and other surgical bodies. Of course, they are coming out with guidelines time to time, and we need to keep updated ourselves. One thing is very sure, that we all have to consider all the cases. Now when we open up for elective cases, all the cases should be considered as COVID-19 positive, as we did earlier with HIV cases. So we need to take all the precautionary measures when we are dealing with the planned surgeries. And I strongly feel that one of the surgeons, one of the team members has to be there on the hospital infection control committee to get the knowledge of what's happening in the hospital front. And also, as Dr. Shivaram right now mentioned, there has to be a review committee which reviews time and again to plan the future of the hospital and the guidelines, to set the guidelines. Quarantine guidelines, of course, we all know about it and we need to adhere to sometimes when we get infected in the process. The surgical hospitals where operating cases, the surgeries are being opened up, the planned surgeries. If positive cases are identified, may have to shut down a part of the hospital, whole hospital, if the protocols are not maintained properly. And that's the fear, as external agencies might force us to do that. And it's very important that we always report these cases to the authorities. You should be aware that it's a punishable act if not reported or not notified. The notifying authorities are DHO and Communicable Disease Surveillance Portal. And if patients are seen in the OPD and turns out to be positive, hospital need not be shut down if all protocols are followed. But treating doctors may have to be watched, as just now our previous speakers put it, and we may have to watch if at all, if we develop symptoms, doctors and other staff have to be quarantined. Otherwise, we can go ahead with our routine work, and probably the test may be conducted, which will tell us the guidelines. The guidelines like outpatients and inpatients have been covered extensively by Dr. Ramesh. Just now he mentioned all the things: wearing right type of mask, gloves, sanitizations, and then social distancing and checking temperature, and the bigger gap to be required when the patients are seated and the team members, doctors are seated. We need to get the sanitization of the tables, chairs, everything as a routine every day. And as far as possible, virtual consultations in the cities could be done, which I'll be covering it up later. And single entry for patients, screening and checking the symptoms and temperatures, as Dr. Ramesh covered it, showing the robos in some of the cases in high-end hospitals. And all staff and patients could be thermal scanned and retinal scan, especially in the teaching hospitals where a lot of doctors are getting into the hospital and going out. The biometric fingerprints could be avoided using the retinal scan or written attendance. Of course, the grand ward rounds may have to be done with for some time now, as we used to have regularly. And it has to be rounds on rotation. One of the team member with one or two postgraduates or the junior residents can do the round, keeping the distance, safe distance between the patients and the treating staff, and all the details of the patients could be circulated on the group messages like WhatsApp and other media which are available now, and exchange of thoughts and change of treatments could be done through the media. And restricted number of attendants is a very, very important thing, especially in the teaching hospitals where for each patient there could be more than 5-10 attendants coming every day to the hospitals. Those attendants have to be stopped, and whomever we are admitting have to go through the same routine thermal scan and other routine checkups. And using disposable gloves for each patient's examined in the ward should be the mainstay. The most important thing for teaching hospitals, of course, some of the DNB hospitals and also under Rajiv Gandhi University, we have more than 50 medical colleges, teaching hospitals. The teaching guidelines have to be rewritten now. There could be online classes and virtual classes. Rajiv Gandhi University of Health Sciences has already implemented a software platform called Medways, through which the classes are being conducted, and it's free of cost right now for all the teaching hospitals, and the departments can utilize these services. Bedside clinics and operative procedures, of course, could be recorded and demonstrated for UGs and PGs also when we restrict the number of entries to the operation theater. Then clinical case scenarios could be used to teach the postgraduates and the undergraduates. And now we are in the era of simulators. And as you know, Medical Council of India and Rajiv Gandhi University of Health Sciences are implementing simulators and teaching different methods to teach the postgraduates and train the junior doctors. So these simulators can be used instead of physical presence. And of course, online assignment and examinations are going to be conducted from Rajiv Gandhi University. And it's already, the circulars are sent for the various departments. We are also taking inputs from different departments and different teaching institutions, how to go about in the future examination. There are certain guidelines given by the Association of Anesthesiologists and Surgeons. They call it 4 S's, that is space, staff, stuff, and systems. This presentation will address considerations relevant to the return to planned surgery under these 4 broad categories. Now, each category, the preparedness for return to activity is RAG rated. That is red, which says that it's not yet ready, the system is not yet ready for a return. Amber, where close to being ready, but not completely ready for returning back to the planned surgeries. And the green, which indicates ready for a return, where everything is put in place and things are implemented. As far as the space is concerned, we need to evacuate and relocate all the other ICUs which are not so important and which are in the pathway of surgical patient pathway. And as Dr. Shuram just now put it, Dr. Anand was also mentioning about it, nearby alternate centers and independent hospitals and mobile facilities could be found where safe surgeries could be done if the present hospital is not very conducive, and group practice could be practiced. And red in the space, in the red category, we have critical care occupancy fully expanded. It's very, very active, and no planning in separation of COVID positive and the COVID negative patients are done. Whereas amber, there's less critical patients are there, but the planning is in place, but it's not fully developed. But in the green zone, pre-COVID critical care occupancy is maintained now, and COVID-19 and COVID-19 positive and negative critical care bed separation has already been implemented. So such space, if it is created, when we are in the green zone, we can safely go ahead with the planned surgery. As far as the staff pattern is concerned, during the critical period, lots of anesthetists, surgeons, and ward staff could have worked in ICUs, which are being used to treat COVID patients or suspected COVID patients. So, and we may not have sufficient numbers for the planned surgeries, and sufficient number of these staff should be free to return to routine work. And it's always advisable, as I mentioned during the rounds, it's always advisable to shield some of the group doctors, and it always, in the unit, instead of the unit practice, we can practice as a department, keeping some staff reserve, 30 to 40% of the staff always in reserve, and rest 70% can work in the hospital. Because in the present scenario, if the team gets infected or if there's a severe threat of exposure, we can always have another team which is waiting, which could be given a week's time off and come back to work if one team is found to be infective or in the danger of getting quarantined. So it's always a safe practice, especially for the teaching institutions where there are more than 15 to 20 surgeons in the department. It's always better to practice this kind of rotation of staff members. The other group, rotational staff being shielded, as I mentioned about it, and staff reserve is always to be maintained because of the threat of exposure, and substantial number of critical care staff may be required. So as far as the staff is concerned, the red zone is where the anesthetist and the perioperative staff and the consultants and the consultant surgeons were on COVID duty or were exposed or were in the suspected COVID area. The hospital is not planned or not ready for planned surgeries. In the amber, anesthetists and theater staff are still recovering from those duties, and less than normal number of residents and trainees are there. Still planning is underway. In the green zone, the staff have already returned back. They are fully now trained, exposed to take up these kind of responsibilities, and the trainees and residents are sufficient in number. Then only we can go ahead with the planned surgeries. As far as the equipments are concerned, some of the equipments might have been used to treat the COVID patients or suspected COVID patients, and redeployment of these equipments are required from the critical care to the post-operative ward or in the wards, and proper and sufficient supply of anesthetic drugs and perioperative care drugs should be made available when we plan the surgery, and supply of disposable and PPEs. A lot of talk has been done on this, what kind of material should be used and how it should be used probably, and these have to be prioritized, and these should be available. So if the equipments are not available as far as the anesthetic machines and other gadgets, and there are shortage of PPEs and necessary gadgets, we shouldn't go ahead with the planned surgeries. In the amber area, equipment could be available, but the stocks available has limited supply chain, and resupply is not very much assured, and post-operative critical care capacity is very much limited, then it's always a risky. So we are looking at green zone when we plan for surgery. Adequate equipment should be available, and adequate drugs reserve should be available, and PPE and other gadgets, as mentioned by Dr. Shuram, should be available in proper numbers, and also there should be an assurance of supply chain. So then only we can go ahead with planned surgeries. So all this, when we talk about the system, the 4S, the last S, all this should be considered. To return back to the planned surgeries, the hospital may have to invest an additional investment to upgrade the operation theater, the recovery rooms, and new gadgets, the equipments, including the PPE, which is quite expensive. The resources have to be geared up, and facilities have to be defined properly. especially in the in the spacing and operations and the wards facilities where spacing between the patients is required, very much required, and staff pattern already put it. We need to have rotational staff, at least 33% or 30 to 33% in reserve has been advocated at all the time, and 70% of the staff working at any given point of time. And the system where the red zone shows that the COVID-19 positive and negative pathways for surgical care is not developed at all, and COVID testing is not sufficiently available in the hospital to go ahead with the pre-anesthetic checkup, and anesthesia team is not yet ready to do the pre-operative survey. They're not back from treating the COVID patients or suspected cases. In the amber, separate surgical care is planned, positive and negative to treat the patients, but not yet implemented completely. In the critical care for surgery, available but does not fully match the demand. So this is the gray zone where surgery is not safe. In the green zone, COVID-19 positive and negative pathways for surgical care is fully implemented, and anesthetic support and peri-operative team is fully functioning, and COVID-19 testing available and fully implemented and planned properly. So when we are in the green zone, as far as the system is concerned, we can safely go ahead with the planned surgeries. So all these things have to be implemented. So the red zone in the implementation always shows that the planned surgery is not going to be successful, it's going to be a failure, and it may have disastrous effect on the operating team, the anesthetic team, and of course on the hospital, which may lead to shutting down of the hospital. And in the green zone, when everything is ready for yes, including the system is ready, we can do planned surgeries, and it's quite safe for the whole team and the hospital. And amber always shows that the hospital is half ready, but not fully ready in terms of staff, equipment, and the tests, everything. And it's not very safe to go ahead and may have to face a lot of problems when we implement the planned surgery. So what do we do? As Dr. Shuram just now put it, there has to be a teamwork between the employer and employees in coordinating the hospital management. Now, what do we have to avoid some of the complications and the fear of a surgeon getting exposed to the patients in the outpatient? Of course, is by practicing telemedicine. Telemedicine, as you know, if you are aware of the gadgets and the newer technologies, telemedicine is coming up in a very, very big way. And in the last 1 month, at least, I should have received about 10 to 15 telemedicine companies which are promoting, and developing software. The guidelines are recently notified by Medical Council of India. Fortunately, in the month of March 2020, we can safely practice telemedicine. There is a legal sanctity for this and legal protection. It is legal, and of course, legal protection is present for this according to the Epidemic Disease Act. And restriction on prescription has been mentioned in this. Medicines listed in Schedule 10 has to be practiced, and informed consent to be taken from all patients before the telemedicine consultation. And we can also exchange the information as far as the prescriptions and the investigation reports are concerned. And with an informed consent, we can stop at any point of time. If surgeon thinks that patient has to be seen personally, we can call them. All these things have been made possible from the telemedicine side. And I think it's a very safe and a newer technology which could be at least implemented in some of the cities where the society and the patients at large are quite intelligent, are using the mobiles, the newer gadgets. And I would like to conclude this talk by just making few points that the COVID is going to, it's going to stay here for a long, long time probably. Nobody knows how long, could be months or year. And it's always safe to adopt the precautionary measures and take ourselves all the care in preventing getting infected ourselves and our team. Earlier, we used to talk about only patient safety, but the days have come where even we have to think about our safety. As they mentioned in the aircraft, take the oxygen mask and put it on yourself first before rescuing the others. We need to take all the precautionary measures ourselves to safeguard our own team, patients, and also the hospital. So, and for this, there has to be a hospital review committee, hospital infection committee, and also a coordination, more importantly, a coordination committee between the management, that's the employer, and the employee, where employer's duty is to take care of the safety of all the employees. So with these points, I would like to thank Rajiv Gandhi University of Health Sciences, our Vice Chancellor, and all the authorities who have given us all the speakers a good opportunity here to reach all the surgeons of the state. And I'm sure Rajiv Gandhi University has reached all the students and teachers as well for teaching guidelines, and also a lot of COVID related work has been done by Rajiv Gandhi University of Health Sciences, and this is one of the methods where we have tried to reach the surgeons and try to answer some of the issues. And it's going to be an interactive session for all the surgeons. Of course, Rajiv Gandhi University has always welcomed the doctors and the fraternity to approach us for any kind of teaching solutions and methodology. We would be very happy to answer all your questions and queries and also help you out. Thank you very much.
Thank you very much, sir, for this wonderful present. So this presentation was very important. All the hospitals in routine cases, and there are. So it is all planning. How we plan for the surgeries. Excuse me. Hello. Hello.
Go.
Switched off the mobile. Switch it. Aeroplane. Trying.
Hello. Hello. Bantana. Bantana. So since every hospital has started doing the surgery, taking the routine cases for the surgeries, so at this point of time, we should be very careful. It's a stage where we high chances that we'll get infected and infect our families also. So sir has classified into red, amber, and green zone. So one thing is all the patients who are undergoing surgery should get COVID test to be 10 RT-PCR. So we don't know the availability of RT-PCR test available, whether it is available in all the hospitals or not. So at least PPE kit and operation theater facilities should be there, and also there should be 30% reserve staff. It should be there always, and it is the responsibility of the employer to provide safe environment to practice. So with this, we end the presentation. So we can take up the questions, or the expertise are ready to solve your concerns. Questions? Questions here. So the first question is Chandrika Muralidhar. She has asked, for all elective cases, should we get COVID test done? There are many asymptomatic carriers. Dr. Ramesh?
Yeah. Now, this is a gray zone. There is no yes or no. As I mentioned earlier, the problem is not every patient will show up for positive. There are a lot of false negative tests also. 30% of patients, if there are 100 patients who have COVID positive, 30 of them will not show up in the tests. And what are you going to do? If you are very confident saying it is not there and then do on a patient who's negative, and if you're complacent, then you land up in major problems. So this is one major issue that we are facing. The second major issue that we are facing is non-availability of kits. There was a time in Bangalore when there were a few private laboratories which were trying to offer us this test, and so we started sending all the samples over there and got it done. The government hospitals which had the diagnostic facilities were only doing for fever patients, and they were very strict about their approach. But then it became difficult after some time when the private labs stopped accepting these things. Now, for example, every obstetrician wants to get every delivery patient to undergo a COVID test. And there are 2 lakh per deliveries happening. And now where are the kits available? So if you say every surgery you want this to happen, we have practical issues. So though we think it is an advantage to do it, today it is not being possible. And today in the national guidelines, they have not said it is mandatory. They have not said you do it. Rather, they have said you have to follow a universal precaution and then play safe with every patient. So I think looking at all the scenarios, looking at the accuracy not being very good in these tests and the kits itself not available, I think we need to look at universal precautions for every patient who gets into the operation theatre today, rather than look for getting tests done.
Next. Sir, next question to you only, sir.
Yeah.
Anil Kumar Belad has asked this question. In private lab yesterday, in a pregnant lady was false positive. How much to trust these labs?
Yeah, false positive.
False positive.
Yes, this has been a major issue. We cannot totally rely on the test reports. In fact, we had a huge major issue with the government importing about 5 lakh kits, diagnostic kits from China, and this went into 4 major hospitals. All the 4 major hospitals reported to the government saying there is a whole lot of inaccuracy in the test reports. So as far as serology reports are concerned, we are not seeing very good results at all. And even with the PCR testing, we are seeing a whole lot of inaccuracies. So this is still, we are in a phase where things are evolving, people are developing kits, things are not extremely accurate. So when we are in such a circumstance, even the ICMR would not have so much time to go into every detail and get every kit that is coming into the market tested and certify it. And so I think these will happen like anything else. Like we had a lab coli coming in for surgeons, and then we saw a whole lot of complications, CVD injuries. Later on, it got corrected. So like that, anything that is new, that is coming into the market without, which is half mature, is going to have its own fallacies, and we have to accept it. But as I said, not depending on the kits is better. And many times when it is positive, there are many people who always do a double check after a few days.
Sir, what is your institutional protocol for Department of Surgery? Vijay Kumar Rathod has asked the question. Dr. Shivram.
I think this departmental protocol has to be built along with the hospital infection control committee or the COVID committee. Like in our hospital, we have protocol form entering the hospital, then going into the hospital, seeing the patient, outpatient procedure, inpatient procedures, OT, and then coming back and exiting the hospital. So all the protocols are exactly there. This has to be laid in. What dress you have to wear, how to see the patient, and how to sanitize your hand, everything is there. This has to be inbuilt along with the hospital infection committee or the hospital COVID committee. Local committee is the best to decide on this. There should be a good pathway when the patient comes also, how they come in, where they have to go, COVID suspects, where they have to go, COVID unsuspected. No, there is no suspicion of regular patients. Pathways have to be streamlined. Hospital COVID committee is the right authority to do this. We have our own committee and also the pathway for this.
Sir, one more question to you, sir.
Yeah.
How do you sterilize endoscopic instrument following surgery on a COVID patient? Endoscopic instruments.
Okay. So luckily this COVID virus is very susceptible and can be killed very easily. You can imagine that the best weapon we have is the soap solution itself. It can damage and break the phospholipid layer around it and it can kill the virus. Similarly, this is very susceptible. Regular sterilizations, like whether you have ETO or the sterilization with the autoclaving or the steroid, all these things will kill this thing. Many people wash initially with the sodium hypochlorite solution. Sodium hypochlorite is basically meant for fomites, like the OT table and the OT tray, trolley, all these things. Otherwise, regular sterilization is good enough to kill the COVID-19 virus.
Thank you, sir. Sir, next question is from Ravi Kumar. Sir, considering the possibility of asymptomatic carrier, PPEs should be used in all cases. Is it feasible in government sector? Dr. Anand Aladi, sir.
The issue of using PPE is not how whether it's available or what quality PPE you have. It is the question of trying to work long hours with surgery with using the proper PPE. If you are going to say that an asymptomatic carrier is likely to be there and you want to use a full PPE, which includes coverall suit, which is minimum 65 GSM category, then you have a goggles, then you want to have a face shield or a hood, especially for the anesthetist who's doing aerosol procedures. It's going to be very difficult to operate in that sort of circumstances. So yes, if it is an emergency surgery, you have no choice, you have to operate on the patient. And as per the guidelines, if you look at, just to add on to that comment what Dr. Ramesh was making about the testing, there are certain guidelines from the ICMR, and there is no mandatory testing requirement for all pre-op patients in that guidelines, but how that has been circumvented, as there are certain clauses like others which people you tick and then try to get the testing done. So with the false negative, if you're going to use universal precautions, try to subcategorize them. If you know it's a completely healthy young patient, no comorbidities, not coming from a hot area or a containment area with no other criteria as per the ICMR guidelines, where he might be fitting into that area where he's going to be required to be undergoing a testing or is likely to be positive, you may try to relax a bit on your PPE. But if it is definitely suspicious fitting into any of those 7 criteria, definitely, and it's an emergency surgery, definitely use a PPE. Minimum criteria for PPE is all given in most of the websites, the MOH website. Use a coverall which has got at least 65 GSM, then have face complete protection with the goggles which is completely fitting, an N95 mask, and go ahead with the surgery if it's an emergency. But at this stage, trying to be very aggressive and try to do routine surgeries probably would not be advisable. Government setup PPEs are available. In fact, the health department and medical education department together are day in and day out looking at the qualities of PP which are coming in, trying to identify few people and coordinating with the central government to purchase uniform quality PPEs and supply it to every nook and corner of the state and the country.
Sir, one more question, sir. Is COVID swab result necessary for emergency or urgent surgery? Asked by Tosif Kamal.
Once a surgery is emergency and urgent, there is no point waiting for that swab. You have to. And if you are having a patient where you are definitely not clear about the area where he is coming from or is fulfilling into one of the categories, obviously you would have sent a swab for that patient because he suspected COVID. So you have to treat him like any other suspect COVID. After you operated, whether he's put in the ICU or a post-op ward, try to keep them in isolation till the report comes. Once the report comes negative, you can treat him like any other person. But if it's positive, then it will be like any other COVID patient precautions which you will need to take. And that is the reason most of the hospital where you are treating these sort of emergency patients will preferably need to have a separate area for these emergency surgery patients coming in, segregating them, waiting for the report, going ahead with the surgery in the meantime, and after the report, then resegregate them into whichever area has to be sent to.
Sir, many surgeons have asked the question whether we need COVID test for elective cases.
I think Dr. Ramesh answered that to a extent. And if you look at the guidelines, if you just go to the ICMR website and say the guidelines is form which is mandatory to be filled, and any lab, whether it's a private lab or a government lab, now it will be made mandatory to be filling it through the app, and the details have to be entered. There are criteria in that. If it doesn't fit into the criteria, ideally it wouldn't be done. If it is done, it has to be through the app. And like I said, most of them are circumventing the clause of not doing routine by ticking on the clause which says others. And the others, there is a line where you have to fill in the reason why it has to be tested. When you're filling up in the app, it's not mandatory for that to be filled up. So many of them just tick the others and send it off. The labs are doing the test. In Maharashtra, because of shortage of the availability of kits, there was serious concerns of that, and the government decided to take action on those people for filling up the forms as others unless there are specific reasons mentioned in that. So maybe we would be getting away with just doing routine tests, but subsequently we may have to face the consequences for that. But routine pre-operative testing as of now is not one of the criteria in the ICMR guidelines.
So you need not get it done.
No. Okay. I mean, ideally you can't get it done.
Ideally you can't get it.
You can't get it done.
No, but if it is done, it is
If
safe.
it is available, you should get it. If it's available, you should get
Suppose
it.
it's coming from, for example, I think Chandrika was asking about patients, obstetric patients, and one of the latest criteria which was added to the ICMR guidelines was pregnant women coming from containment zone or hotspots are also to be included to get the testing done. So if it is a routine antenatal patient, not in emergency section, planned cesarean or planned delivery coming, but she's coming from a hot spot, you can still insist and get the testing done before taking them for delivery or for cesarean, or admitting them for delivery or cesarean.
I think as of now, whether we can do it or not, whether it's available to do it or not, that has become more important.
Yeah.
If it is available and you have an elective case or emergency case, preferably do it and then do surgery. But in a lot of areas, especially our semi-rural areas,
It's not available.
It's not available. Even if you want to do it, it may not be available. So if it is available, preferably go and do it, even for elective, emergency, everything, and then do the surgery. If it is not available, take all precautions as if this is positive and then do the surgery.
There are a lot of fallacies here when we look at these red zones, hotspots. I've had personal experiences of people who give a wrong address and then get their treatment done. Even patients coming for a delivery, they don't say they're from hotspot. After the delivery, when the birth certificate has to be made, they say this is our address and say this is our hotspot. They've come from hotspot. So I think beyond just the straightforward question of who to test or what not to test, I think we are having a lot of difficulties and we'll face them as the days go by.
Sir, one more question. should surgeon and anesthetist should get COVID test, throat swab, done before surgery for medical legal aspect? Abhinandan has asked this question.
No, there is no guideline on this, and also there is no necessity at present. It is like asking whether surgeon and anesthetist should get HIV test done before doing surgery. So these are all gray areas, and this cannot be not necessary. See, you can't totally depend on the test. That's what everybody has highlighted. So go by the zone from where they are coming, whether they have fever, cough, throat pain, symptoms. So many other things also take into consideration, and just don't totally depend on the test and fall into this problem. So consider everything together and then decide. Surgeon and anesthetist, there is no need to get it the test done.
If it is going to be a legal problem or something like that, we already discussed about the consent form, especially patients who are walking into the OPD, which says that I am ready to undergo tests, and also I'm aware that I may get infected in the hospital surroundings by non-symptomatic. So the consent form could contain all these things. So question of legal problems doesn't arise. So we need not go for a checkup as a routine.
Dr. Syed has asked the question, sir, how is telemedicine feasible? There is just inspection, there is no proper examination, and if error occurs, diagnosis and management on telemedicine platform, patient will sue us. How do you go about it?
See, I already mentioned about it, about the telemedicine. There is a legal sanctity to it, and legally it has been allowed. And many diseases could be treated, which could be treated without surgical intervention, could be prescribed if you feel that it's a simple, gastroenteritis or gastritis, things like that could be treated. Or if you see a swelling, sebaceous cyst or lipoma, a diagnosis could be made and patient could be reassured over the telemedicine platform. And at any point of time, if you think that you may have to see the patient, you may call him, and that has been allowed. And in cases where the diagnostic reports are confirmatory, you can also go through the diagnostic reports through the telemedicine platform, and it has been allowed to interact. So it's quite safe to some extent, and probably things to years to come or days to come, it's going to develop, the area may develop some more.
One more question, sir. You want to talk, sir?
Just to add to that, there are very clear guideline from the medical council which is available on the website as to what are the things which can be done on telemedicine, what are the drugs which you can prescribe, what are the drugs you can't prescribe, and what are the types of patient you can see. So you can just go to the website. The latest guidelines on telemedicine practice is available on that.
Telemedicine Act has
been passed.
Sir, one more question to Dr. Bhagwan, sir. Sir, our hospital is located in red zone. So can we start the hospital and operating? It's asked by Dr. Guru Basavanna.
Definitely, yes. When the government has given go ahead, and if you want to do planned surgeries, all the precautions have to be taken, like how we mentioned, and prioritizing the COVID test as we all discussed here. In case if the facilities are available in your hospital or nearby setup, it's always safe to get the test done on these patients when you are planning for surgeries. But whether you get the test done or not, when you're planning to operate as a surgeon or to see the patient, it's better to take all the precautionary measures, of course, with the safety kits like PPE and all the gadgets which have been mentioned may have to be used judiciously and in such a zone. Anything you would like to add?
Sir, when PPE kit is not available, can we go away without wearing PPE kit and operate? Because of limitation of PPE kit availability.
No, this is what we said. Take not only the patient safety, we have to take ourselves very carefully, take care of yourself and also your healthcare workers. If there is no PPE And legally also it has been told that you can refuse to operate. There is no problem that you can send the patient to some other place. So don't operate, don't take yourself into the risk and also other healthcare workers into the risk. If the patient comes positive, everything will fall on you. So better not to do that. Without proper PPE kit, the strongly suspected patient of COVID, healthcare workers should not manage, and also we should not operate. Right?
So again, please throw light on guidelines of PPE usage in OTs, COVID hospital and non-COVID hospitals.
Yes, already mentioned. I think that has been covered. Basically, whether it's COVID, non-COVID is secondary. Depends on whether you're considering that patient as COVID and going out with universal precautions. Whatever, once you have decided it's a universal precaution, you need to have one with respect to preparing the OT. More than normal time has to be anticipated for getting the patient ready. Generally, the anesthetists go in, minimum anesthetists. There are also number of, there's a very good article which has come up in the Indian Society of Anesthesiologists have come up with guidelines for that. How many anesthetists, how many OT technicians ideally should be there? If it is with OT technician, how many anesthetists? Without OT technician, how many anesthetists? They go in, they do all the patient intubation, anesthetizing, etc. Surgeon is not allowed into the OT till the patient is completely anesthetized and ready. And subsequently, once it is all ready for, it takes around 15 minutes extra time for the surgeon to go in. Again, PPEs are to fit the minimum criteria required. PPEs are available which are also pre-sterilized. In some situations, you might not have pre-sterilized PPE, then you might have to scrub, wear the PPE and then use a regular sterile gown on that. The use of mask, N95 mask, the use of goggles, all those things are the same which I mentioned earlier. And post-surgery extubation, preferably to be done in theatre as much as possible, extubating the patients. The surgeons go out completely, then the anesthetists start the whole process of extubation. So these are very clear-cut criteria and guidelines which have come up from the Indian Society of Anesthesiologists, which is available on their journal and freely available in the website.
Sir, one more question to you, sir. Dr. Divakar Reddy has asked, when do you repeat swab in a positive patient at the time of discharge or third day or after 48 hours?
If a patient is tested positive, the minimum time you need to wait is 14 days. After 14 days, you do the first test and immediately the next day do the second test. If the first test is positive, you don't do it on the second day, you do it on 3 more days later. So the cycle continues till you get 2 consecutive tests negative, 2 consecutive days. So the first test is done 14 days after he's been admitted, and if that is negative, you do the second test the next day. 2 consecutive days test being negative, he is considered cured and discharged, but continues at home quarantine.
Sir, your experience with PPE, how convenient for major surgeries, or is there any alternative?
I've had an experience of doing these things. It's not pleasurable experience wearing the whole PPEs with the hoods and all those things. I don't know how these orthopedic guys do the joint replacements because they're using those things for quite some time. Maybe we have to get used to it. I've had to do some surgeries where I had to do very fine things like suturing, laparoscopic suturing and all that. And it was quite cumbersome. I should say it wouldn't bring the best of my skills on the table. So it's not so easy. It's definitely cumbersome.
Anand sir,
see, there are many specialties where you need to use loupes or the microscopes and then operate. With the present available PPE, it is almost next to impossible to wear them over your loupes and do fine surgeries. If you have a microscope, that's fine. And like I said, doing skilled surgeries for prolonged hours, even those people who are going and working in the wards, not even the ICU where they are doing intensive care, just wearing the PPE and standing for a couple of hours is going to be very tedious. They come back completely dehydrated. Some of them have complete skin excoriations on the face and everything. So at the present situation, I think we should restrict ourselves to emergency surgery where we have no choice, and those the situation we have to use and do the minimum. The other thing which is coming out in this crisis of COVID is that many guidelines are changing. More and more conservative or alternative methods for treatment for acute surgical emergencies are coming up. Consider those before you start off straight away operating. I mean, one such typical example is appendicitis. Already there have been earlier lot of conservative management of appendicitis, perforations, localized peritonitis, perforated gallbladder. So there are a lot of these conditions where you can still try conservative management without directly going in for surgical management. So consider all the situations and try to do the minimum. Obviously, you have to use PPE when you're going into theater in those sort of situations. So try to do as minimum and as quickly as possible.
So I being an oncosurgeon, we operate for 5 to 8 hours. So we don't have any options and we are using it for the safety of ourselves and for the patient. Sir, is HEPA filter an absolute necessary for medical college setup? Because you have mentioned it. So what to do in medical college setup?
Most of
Kumar has asked.
I think you can check in our operation theater. These are all now routine specifications. HEPA filters will be available in the OT itself, and most of the air handling unit, they use it. It will be available. It's not a very expensive thing. NABH criteria, it's already included, and they check all these things when they come to the thing also. Most of the medical college hospitals and good hospital setups, they have HEPA filters, which is available.
I'd like to add one point here where we're talking about negative pressure operation theaters. Now, a lot of all my colleagues spoke about it, saying that is one of the ways to act on safety. Now, they also mentioned about the cost that is there. Dr. Anand said it will cost anywhere between 10 and 25 lakhs to change the infrastructure inside the OT to have this negative pressure OT. Now, what we can actually do is we make sure that nobody opens the door is closed, and once the surgery starts and nobody is traveling in and out, and then we wear all the PPEs and then do the surgeries very carefully. I think that would suffice as to now, because he mentioned after 6 months, what are you going to do? So a lot of capital investments are going into change the whole scenario, and I don't think most hospitals are willing to do that for a temporary thing. I'll ask Anand to give some comments.
Sir, is it very costly thing, sir, if it is not there? Do you have any idea?
As of now, I don't think any
Air exchanges
infrastructure has. Air exchanges, they have to increase the pressure. They have to increase the amount of pressure. That is, the positive pressure is coming, and then the negative pressure in the 4 corners should be increased. That can be done in the settings of all the OTs. If they do that and maintain the exchanges very well, then that would suffice.
And also the timings in between the surgeries when you are
Yes,
doing
that is
7 to 8 surgeries.
You have to clean up everything with sodium hypochlorite, and a minimum of 20 minutes is the gap between one case and the other case. You have to strictly follow that.
You would like to add something,
So
sir?
basically, it's like local modifications where you don't have the HEPA filters, the negative pressure system. You can use a little larger exhaust if you want to modify without too much of expenses using exhaust, but the air which is going out has to go out into a closed area, and from there you should have ways to allow those to be sent off into the atmosphere if you don't have a treating unit there. Basically, the negative pressure, these ready-made negative pressure systems, what they do is they treat that air which comes out from that OT into that closed area with various ways. So if you don't have that, you can use large exhaust, allow that to go into a closed area, and then use pipes like you have in your chimneys in the kitchens, what you have, that sort of thing, which takes it out completely and allows it to go into the atmosphere at a very high level. The second thing is when you are using the AHUs, normally what happens in the hospital, though the AC is off, the AHU still keeps circulating the air within the hospital. So the air which is going from the OT out would be going into certain common areas in the hospital. So for that system, we should try to preferably have an area in the hospital which has a separate vent of that air and not go into the general area, and also have an AHU which takes air from the exterior rather than recirculate the air from the same hospital's area.
So one more question, sir, very interesting. What is the time gap between the 2 patients in the OPD? So when you see one patient, so next patient, should we clean with hypochlorite solution there, and should we maintain any gap in between the two?
See, there's nothing called gap. As far as possible, we try not to touch the files that the patient has brought, not to touch the records that the patient has brought. If I've written some prescription, usually our habit is to take the same thing and keep writing in the same paper. Don't do that. You write a new prescription page and then give it to them. And every time the patient has come and gone, you have to clean up those areas with either sodium hypochlorite or alcohol based solutions. And every doctor has to wash his hands with soap and water. So as far as we maintain these things, I think it's fine. There is no spelt out timing in the OPD as of now in the guidelines.
Overcrowding. Now, in the OPD, patients have to maintain the physical distance, so overcrowding should not occur. So what we are doing is, earlier we used to give 15 minutes appointment. Now we are giving one appointment gap between 30 minutes, so that 15 minutes appointment is over, everything is cleaned, ready for next another, so that patients are also maintaining distance and there is no overcrowding in the waiting area and also when they come for procedure or anything.
Sir, we'll take only few more questions because we have a shortage of time. For Anand Alladi, sir. Sir, emergency operation and patient who comes from COVID endemic area, or even if she is negative, should the patient be put on HCQ and azithromycin prophylaxis in the post-operative ward? Is there any role of prophylaxis?
No, prophylaxis for HCQ prophylaxis, azithromycin is not used as a prophylaxis. HCQ is used as prophylaxis, and as of now, because there have been contradictory reports on HCQs, its risks and all those things associated with it, as of now, the emerged guidelines says that it is used for healthcare workers who are working in COVID wards and COVID-related patient wards, or patients who have been exposed to COVID positive patients. Or people have been exposed to COVID positive patient without PPEs or without any other protection. So just considering them coming from an endemic area would not be ideal. But anyway, though emergencies, during the emergency surgery after admission, because they are from the endemic area, we would have tested, especially if it fit into the criteria. So waiting 2 days for the report to come, or not even 2 days, but within 24 hours you get the report. If it comes back negative, there is no requirement to treat them. If they come back positive, they didn't go to the whole cycle of the treatment protocol of a positive patient.
ICMR recommendations are there.
There are only for two groups which are there. One is the healthcare workers working in COVID areas and those who have come with asymptomatic.
Sir, one more question. Is it mandatory for a private hospital to treat a patient at present, or medical legally we can send the patient, refer it, and if any problem happens on the way, the patient is, we are referring the patients.
See, you are not going, it's very unusual to get a patient who's positive saying, I am positive, I am coming to your hospital. Okay. Most of the mild symptomatic or asymptomatic patients would have gone to either a fever clinic or gone to a hospital where they suspected and they would have been referred to the fever clinic. The moment you go to that area and you are positive, you are directly referred by the government to the government hospitals who are treating COVID right now. The situation where you get patients who are coming with acute respiratory symptoms, the so-called SARI patients, would have been admitted in the hospital because of respiratory problems and they are sick. Unless you have proven that it is positive, you cannot say it's positive. So most of the hospitals, what they follow nowadays, you have isolated areas for these patients who are SARI and grossly symptomatic and sick, and send off the swab. If the swab is positive, then they can still shift under control to the COVID hospital. They don't have to mandatorily treat there. But if it is negative, then you continue treating in the same hospital like any other acute non-COVID patient.
Sir, suppose a patient has come with respiratory distress. So you are suspecting that that could be COVID positive patient, and you are referring to a boring hospital, suppose. So on the way, if anything happens to the patient, is that hospital responsible?
This hospital, if he is come with acute respiratory distress, till he is undergone a test and proven it is COVID, all of them are not going to be COVID. So if he is stable enough to be shifted to another hospital, undergo the test and then segregate depending on the result of the test, fine. But if he is coming in really sick, where he requires medical management acutely, you cannot refuse him just because he is having symptoms of respiratory distress.
Sir, before the small hospitals, 20-bedded, 30-bedded hospitals were not working. Now they have started working. So this will be the major
This
problem.
will be the problem. So they will preferably try to keep a small area. I mean, you're not going to get more than 1 or 2 patients in that small hospital suddenly coming as a group with that sort of symptoms. So try to keep one segregated area like an isolated ward. You need to treat that fellow. The swab report comes within 24 hours, and you can easily, if you are in a small setup, it is advisable for most of these hospitals to have a contact of the government nodal officer of that place.
Okay.
You just call them and tell this is the thing. They will get you a report, and within the time you got the report, if it's positive, you can always shift them under controlled conditions. If it is negative, you continue treating. If your hospital, it's just like any other nursing home which was otherwise not having an ICU. Obviously, you wouldn't admit a patient who's come requiring ICU care.
So you mean to say we should have a triage system there only?
Yes. Triage
So,
within whatever.
segregation of the bed. You
Yeah.
mean to say
And the
segregation of the
smaller
bed?
a hospital and smaller the place, the chance of multiple patients coming is less. So you have a small segregated area for an uneventual situation where that sort of patient comes where you don't have time to refer them. If the patient is stable enough to be referred, you can always say we don't have facilities to treat an ICU patient in our hospital, so we are referring to a higher center, which would have happened in the normal circumstance also.
So every hospital should be geared up for all these things, problem happening in the future.
Definitely, to some extent they should have. I mean, it's like saying I cannot treat
Okay, sir.
just because you might have COVID. If you come in, it's like a road traffic accident patient suddenly being brought. You
Yeah.
can't say I want treat.
Okay, okay. Okay. Thank you very much, sir. There are many other questions, but due to shortage of time, I think we can stop at this stage. And you can mail or you can call up or to all the panelists and to the Rajiv Gandhi University website. If you have any doubts, any concerns, you can mail to us. We'll definitely reply it. So one one important thing I want to enlighten here. A circular has been sent from the Rajiv Gandhi University by the Vice Chancellor not to remove any staff abruptly in a medical setup, medical colleges, and to reduce the salary or cut down their salaries, and cut down the salaries. So it has been strict instruction from our Vice Chancellor. If anything happens like this, and from the government also, if anything happens like that, please report to the Rajiv Gandhi University. We would be very happy to consider it and do the needful. So at the outset, I thank our Vice Chancellor for organizing these things, and Dr. Bhagwan sir for organizing such a wonderful session. I'll thank all the panelists who have come all the way in their busy schedule to enlighten all your concerns. Thank you very much. So I'll hand over to Dr. VC sir.
Thank you, Dr. Pandu. I think all of you had a very fruitful session here today. The intricacies of practice of surgical practice during this situation, pandemic situation, has been discussed at length. I hope all of your doubts have been cleared. Even in case further, if you have any doubts, you can always mail it to COVID-19 RGUHS@gmail.com. I'll repeat, COVID-19 RGUHS@gmail.com. Very simple to remember. So kindly address your questions to us. It will be again sent to the experts and opinion taken, and then the reply would be sent to you promptly. This is what the pursuit of disseminating authentic knowledge to all the concerned healthcare workers is a big task that RGUHS has taken up, and we have been doing this relentlessly, and with the support of all the experts. Whenever we are called, no experts has denied so far. They have been very cordial, very cooperative. All of them have come and spared their time and efforts in furthering the cause of spreading the right authentic information to the healthcare workers. So with that in mind, I thank all the panelists today, all the faculty members, Dr. Pandu, Dr. Ramesh, Dr. Anandaladi, Dr. Shivram, and Dr. Bhagwan as well. So with this, I think we'll conclude today's program. We are signing off from the studios of Rajiv Gandhi University of Health Sciences after this fruitful program. Thank you one and all. Thank you so much.